Hi, everyone. Good morning. Oh, right. Sorry. Good morning. Um, Hope everyone's doing well on this somewhat dreary Friday morning. I'm very excited for this presentation, as I am for many, but I think this is a topic that will hits my heart very closely, and I think we see this a lot as infectious diseases physicians, the false positives for HIV testing. And I know Michael has done an interesting analysis, and then there's something else on top of it. But let me introduce Michael Tang for those who don't know him or haven't seen him in a while. um, he completed his undergraduate degree at the Ohio State University in biochemistry. He did medical school and internal medicine residency at WashU School of Medicine before coming to UC San Diego for his ID fellowship. He is currently an associate physician in the Division of Infectious Diseases, in infectious diseases and global public health. And in his free time, he enjoys traveling, hiking, exploring the beaches of San Diego, and spending time with his wife and daughter. I will just also add that Michael, after completing his fellowship, he's now one of our fabulous clinical ID doctors. So he spends a lot of time seeing patients in the hospital, which is no easy feat. So I'm glad he was able to return to this work for a little bit. I will turn it over to you now, Michael, and I'll be paying attention to the chat.
Thanks, Joe. Part of the reason why I have two different topics here is because I wasn't entirely sure I was going to have enough information on just one topic to fill up 45 minutes. So we will jump right in. Thank you for the nice introduction. I do not have any disclosures. So a brief little outline of what I'm going to talk about today. First topic is going to be on false positive testing for HIV. First going through a little bit of background and review of the literature, and then talking a little bit of the experience at UCSD through the Focus program. And then, as Jill mentioned, I've been working a lot in the hospital in my job as a clinical infectious disease doctor at UCSD. And I wanted to talk a little bit about this interesting case presentation of encephalitis I saw back in July, which the patient's still in the hospital. So that should tell you a little bit about how complicated this course has been. Okay. So I first wanted to talk about the evolution of HIV screening guidelines. Because I found this to be very interesting. It kind of tracks with, I guess, our understanding of HIV over time as well. So, the first sort of publicly available testing for HIV came out in the mid-1980s. And really, at that time, it was primarily being used to screen the blood supplies to try to prevent transmission through that source. But really, our understanding of transmission through sexual contact or other ways wasn't quite well understood at that time. And so, public health organizations in the U.S. Didn't have any particular guidelines about general screening for the general public. And so that's kind of where things start out. A couple years later, into 1987, the U.S. Public Health Service, based off of the better information that we had at that time, said, high-risk populations should really be screened for HIV, as well as those who are seeking, in particular, those who are seeking any sort of testing for any STIs or sexually transmitted infections. By the early 1990s, the CDC ended up recommending voluntary HIV counseling and testing to include all hospitalized patients, including those presenting to emergency departments. And an important part of this is that this counseling portion of this, which really requires providers to talk to patients about their potential risk factors and what HIV testing may be and things like that, And although, I was not a provider back in the 90s, I assume similarly, physicians were very busy with things and sometimes did not have time, or, voluntary HIV screening and counseling is not on their top of their priority list. By the early 2000s, recommendations continue to evolve, and based off of perinatal HIV transmission, we recommend that all pregnant women be screened for HIV during prenatal care instead of sort of voluntarily counseled and then tested after that counseling. And so this sort of opt-out testing, this is the first sort of group that we had sort of an opt-out testing sort of approach. And this change in 2001 was important because it sort of showed that this opt-out approach could be useful and could be cost-effective potentially too, and would also lead to decreased transmission or decreased prevalence of perinatally transmitted HIV. In addition to the pregnant woman recommendation, the CDC also recommended that HIV testing be offered to all patients in high HIV prevalence healthcare settings, and then in low prevalence settings, sort of doing targeted testing based on at-risk screening. And so I think that last portion, again, is telling because it can be very difficult to find the time to do that sort of at-risk screening when there's a lot of different priorities at play as well. So in 2006, the CDC revised their guidelines after some review of the data. And two things were happening. One was that the universal HIV testing in pregnant individuals was found to reduce perinatal transmission. So this universal opt-out testing clearly was working. But, providers were saying that really they didn't have the time to conduct these risk assessments. And they saw that, where prevalence was relatively high, at least 0.1%, HIV screening could be as cost effective as other established screening programs. Sorry, I meant to say relatively low at 0.1%. So in 2006, the CDC ended up changing their recommendations that everyone between the ages of 13 and 64 get tested for HIV at least once as part of the routine healthcare. And they suggested the use of opt-out screening. And then they say, those that we may consider to be higher risk, so the ones that we should be sort of doing HIV counseling and then testing, those at higher risk should be tested at least once a year. So I wanted to also go over the most recent HIV screening algorithm. And so this comes directly from the CDC. So the current recommended screening test is the HIV-1/2 antigen antibody combination immunoassay, or the fourth generation screening test. And if they first test positive on a screening test, then we go down into a differentiation immunoassay, where if all this testing ends up being negative, we go down the route of a HIV-1 nucleic acid test, or NAT. And so it's when we get to the setting where that nucleic acid test is negative that this is where we're talking about this being a false positive test. So a little bit of a definition. False positive HIV test is when someone is not infected with HIV, but receives a positive HIV screening test. Overall, we know that these false tests are rare. And so going through the literature, the sort of first reports in the 1980s showed in a military screening recruit program where they screened 135,000 military recruits. They only found one false positive test. They did find some true positive tests as well. And so they put their false positive rate at 0.0007%. They felt like this was an excessively low rate of false positive testing. Similarly, in the early 1990s, through a voluntary blood donation screening, retrovirus epidemiology donor study looked at false positive results there. And here they found kind of a similar false positive prevalence. So specifically among all donors, they found, from more than 5 million donors between 1991 and 1995, they had 421 donors that were positive. And at this time, they were doing screening through Western blot. And so 421 were positive by Western blot, with 39 specifically concerning for false positive testing because they didn't have reactivity to the P31 band. And then of those 39, 20 ended up being PCR positive. PCR negative. And so in total, that puts the prevalence at 0.0004%, but still only about 5% of positive Western blot donors end up being false positive. So still seems like an exceptionally low rate of false positive prevalence. And then just talking a little bit about their current tests that we have, in the early 2010s, we did transition from third generation to fourth generation tests, where the fourth generation test includes T24 antigen as part of the test. You can see that there were increases in both sensitivity and specificity between third and fourth generation tests, from 0.998% to going from specificity 0.9913 to 0.995%. But these aren't sort of dramatic changes. And both tests seem to have really good test characteristics for screening to minimize false positive tests and also hopefully minimize false negatives too. But as these recommendations come out, we are starting to test lower risk populations, so populations that have a very low prevalence. So even with this high sensitivity and specificity, we're seeing decreases in positive predictive value, and also seeing a lot of false positives. So after the recommendations for universal opt-out perinatal screening occurred in the early 2000s, there were a number of studies that looked at false positive rates in sort of prenatal care. So in a study out of Japan, they saw in two maternity hospitals there that the fourth generation test only had a positive predictive value of 3.7% when they used a single test alone. It was only when they added in a second different fourth generation test that they could actually increase the positive predictive value of the sort of screening algorithm then up to 100%. And so, part of what their reasoning for why they found such a high false positive rate was that their prevalence for HIV among pregnant women in Japan during this time period was extremely low. So 0.009% compared to 0.15 to 5% here in the US. So that's kind of what they attributed this very low test performance in that setting. Similarly, in South Korea, they found a fairly low positive predictive value of 31% for the overall population. But when broke it down, specifically for women, it's found to be not very beneficial. They did, however, look at sort of changing the test cutoff. So they were using, I think, one of the testing platforms that uses signal to cutoff ratio. So when they increase that ratio from what's currently accepted as the cutoff of 1 to 6.6, they got a sensitivity that stayed at 100%, but specificity that increased to 99%, which they said could be beneficial for sort of their overall screening platforms. And then, one that seemed a little bit more relevant here in the U.S., the Philadelphia VA went through a transition period where they, in the 2016, 2017, they were using the third generation HIV screening platforms, and then later in 2017 into 2018, they transitioned to the fourth generation platform. And interestingly, they did actually find a decrease in the false positive rates from 0.37 to 0.09% during that transition, which seemed to support that these newer tests are better performing, potentially from a specificity standpoint, and seemed to say that that hopefully we won't be seeing a lot of false positives. So what conditions are actually associated with false positive testing? I went back to look at some of these case reports over time. And in the early 1990s, a lot of the case series seem to point to sample mix-up or passive immunization. So this case series, a couple patients that I think it was 5 patients at the University of Toronto and Calgary, they, in 50% of the cases, they pointed to sample mix-up as being the likely cause. They also commented that there were some people that were maybe some of the sample mix-up was actually somewhat intentional by some healthcare workers that were wanting to screen themselves anonymously for HIV. So they were switching their own blood for patient blood in this setting. And they comment that that's probably related to sort of poor understanding of availability of confidential and free testing for HIV. But there's also some other conditions too. So there's been case series that reported patients having systemic lupus erythematosus that tested positive for HIV via ELISA, and that's thought to be related to cross-reactive antibodies. And they note in for that particular case series that patients after treatment of their lupus later on tested negative in both those situations on antibody testing. And then another source that I think people in the HIV research field are very familiar with, and definitely makes sense, is that HIV vaccine trials have high rates of vaccine-induced seropositivity among vaccine trial participants. But this actually varies significantly based off of the specific testing platform, as well as the specific vaccine that's being tested as well. So I saw rates, as high as 80% for the adenovirus 5 vaccines versus, much lower, 5% for some of the DNA, RNA-based platforms. And then, other things that have been identified, so pregnancy, as I've already kind of talked about, some viral infections, both CMV and SARS-CoV-2, and then hypergammopathy of hematologic malignancy has been linked to false positive testing. So what's the potential cause as to what's going on with the false positive? So it's thought that there's some sort of alloantibody that's occurring in a lot of these conditions, either from pregnancy, transfusion, or autoimmune disease. And I think this was probably a bigger issue than some of the earlier testing platforms that we used because they were using our testing platforms had a lot of sort of cross reactivity with some of these things. As we've gone into more synthetic peptides and recombinant proteins, that's really helped to improve our specificity as generations of HIV testing platforms have progressed. There are some other conditions that have been identified, in particular heterophilic antibody interference, which is suggested as a potential cause. You can see this in this diagram over here on the right. This is what's supposed to be happening in an ELISA test. You have your capture antibody, you put in your sample, and this is your particular antigen. And then you have a labeled antibody here. And this is supposed to represent our true reactive test. On the other hand, in a false positive test, antigen is not necessarily presenting here, but we have this heterophilic antibody that actually is linked to this inappropriately, leading to a false reactive test in there. Additionally, just start thinking about SARS-CoV-2 as well. There have been 3 reported cases of false positive HIV testing following SARS-CoV-2 infection. And some of that's thought to be related to similarity between the spike proteins. And then interestingly, there was a vaccine candidate out of Australia and the University of Queensland that had to be ended up being abandoned because as part of this is the protein-based vaccine platform, and I guess they had used some viral proteins from HIV vaccines that were having some cross-reactivity on the HIV screening test. So I think as many as 40% of the 20 to 40% of the study participants were having HIV screening positive tests, far higher than to be expected. And some of this may have led to people falsely saying that you could get HIV from a COVID-19 vaccine. So unfortunately, leading to a lot of misinformation and leading to that potential vaccine candidate sort of being no longer looked at. Specifically looking at perinatal screening for HIV, we know that there are some race and ethnicity associations in what we're finding. So in this study out of Houston that looked at screening tests for pregnant mothers in the Houston area between 2000 and 2001, they found this positive predictive value sort of varied significantly based on race ethnicity, going from 83% for Black women compared to just 10% for the Hispanic women. And the study authors hypothesized that this could be related, not because there's anything in particular going on within the Hispanic women population in terms of something sort of a higher prevalence of autoantibodies, but that there's an extremely low HIV prevalence in that population, and therefore just seeing very low positive predictive value in that setting. And you can see here on the right, this is their analysis where they did a regression here, and they found an adjusted odds ratio for being Hispanic and having a positive test, and whether or not that's a false positive test, their adjusted odds ratio is 35. So highly predicted in that population for false positive HIV testing. Other predictions they found, being married, having fewer children, and then no history of any STIs or multiple sexual partners. All those were sort of led to more likely having a false positive HIV test. So these universal opt-out screening programs has led to increased identification of people with HIV, but in a survey among ED providers, seeing patients suspected of having a STI, only 10% of those providers actually encourage HIV testing on the ED, whereas 30% ended up referring to HIV testing sites. And a lot of this, they report concerns related to lack of follow-up, and then questions about disclosure counseling and things like that, and sort of not wanting to manage that as an ED provider that's seeing someone for episodic care. And so, in addition, these high false positive rates could potentially lead to sort of delayed disclosure of HIV diagnosis and delay of HIV treatment initiation, because if there's so many people testing with false positives, that may lead to sort of people wanting repeat testing to sort of verify what exactly is going on, and maybe sort of being skeptical of the initial results. So I'm going to talk a little bit about this focus program here at UCSD. This is the opt-out HIV screening program conducted at the two UCSD emergency departments here in San Diego. Started in July 2017, currently ongoing. And we've used two different fourth generation testing assays just based off of what the labs, the clinical labs at UCSD is doing. And one of this Abbott assay, and they have more recently transitioned over to this Roche assay. So we kind of talked about this false positive definition, and then whereas those found to have a positive screening test and then a positive differentiation assay or a NAT test, those are people that are confirmed to have a true positive HIV screening test. So some of the preliminary data, I apologize if it's not fully completed data yet at this point. Through February 2022, there were 50,740 HIV screening tests that were performed over, I guess, 4.5-year period. And in total, there are 250 positive results during that time period. About half of them are true positives, and about the other half are false positives, and then 33 of them actually ended up excluding from the analysis because many of those were known to be false positive in the past and repeated testing again. And then some of them were also known people with HIV that, the screening algorithm, for whatever reason, that provider didn't remark that they're already known to have HIV, already on meds, or some sort of lab error that occurred. And finally, there were some that were excluded because we didn't have any confirmatory testing. So maybe the amount of blood that was collected wasn't enough to actually perform their confirmatory testing. Now, on the right-hand side, you can see for the false positive prevalence based off of quarter of the year. You can see that initially actually started out relatively low, and there actually does appear to be an increase over time through this testing, although there is definitely variability, especially between 2000, sort of late 2000 to early 2022. So this amount is quite high, but there also was a change in the testing platform right around here between the Abbott and the Roche assays. So I just wanted to talk about sort of some predictor results, and these are all unadjusted analyses. And some of the issues with this is that when we go back and look at all these people's medical records, often ED records are not 100% complete, in that not all sort of risk factors for HIV are sort of screened for, in particular because often people are presenting, and part of the purposes of this is that people are presenting for reasons completely unrelated to STI testing. So they have a cold, they have a fracture, they have some sort of musculoskeletal injury. ED providers do not ask necessarily take a sexual history or ask about injection drug use or things like that. So that led to sort of incomplete data on a lot of these predictors. So these are all unadjusted single variable analyses. But you can see in these single variable analyses, looking among all positive tests, the predictors were suggestive of a false positive test for older age, female gender, as well as history of flu vaccination, and this Roche test is also associated with increased risk of false positive testing. On the other hand, having reported being MSM, or injection drug use, those two factors were associated with having true positive tests. And I think this is kind of telling in that I think a lot of these factors just represent who is low risk for having HIV or have a low prevalence of HIV in this population. I think in particular this history of flu vaccine likely represents that these are individuals that maybe are in care in other places, or a primary care provider or things like that, present to ED. And those were the few people who actually had flu vaccination history actually documented, versus most people did not. So a little bit of thing here that we're seeing with the data.
Michael, there was a question there. Sorry if you said it. Was that flu vaccination ever? Like, yeah,
yes,
ever.
That's flu vaccination ever. And you can sort of see that this is not a question that we always ask people. And so it does get a little bit difficult in terms of interpretation. Interestingly, the false positive rate was higher than reported at some of these other in these other studies. So we had a false positive rate of 0.23% compared to the Philadelphia VA study at 0.09. I think the populations are a little bit different, and also the testing scenarios are also a little bit different in that this is purely through emergency department versus ambulatory testing too. So maybe that can be cause for some of that. There's also sort of pointing through things. I really think there's, in reading these case reports about people having false positive testing, and then also being one of the providers now that looks at these false positive tests, there's a lot of anxiety and a lot of things that people go through when they're notified about a positive HIV test. And I do think we have to be careful about making sure that we approach these things very sensitively for patients, and realize that there is potential trauma for patients that are notified that they test positive for HIV and then being told later on that they have negative. For example, I was reading one of the cases where a married man in his 30s falsely tested positive, and then later on, I guess before he found out that it was a false positive, he disclosed to his family that he was also having engaging in sexual contact with men as his risk factor, and then later on having a lot of downstream sort of a lot of downstream potential harm as a result of that false positive test. I think the other thing to identify is that I do think that one of the things that we've done here at UCSD is, we have case management that's involved in sort of connecting, following up these tests and then connecting people to either PrEP or to other programs as needed. And I really think that those sorts of programs are needed more and more for the ED, in particular, as many patients present to ED don't have a regular PCP that can follow up questions. So I was actually going to transition to this other sort of case presentation and go through that relatively quickly.
Michael, if it's okay, I just want to make a few comments, having,
Yeah.
and Susan may want to as well, just sort of seeing this program through its inception, in 2017 till now, and how it's evolved. I don't know if you could go back one slide. And maybe it was, I don't even know where it was. I think it was one slide back. It wasn't, it was talking about some of the false positives, and you said a lot of stuff related to, anxiety around the results. When we first started the program, all of our confirmatory testing was happening at the county. So there were delays of up to 2 weeks before we'd have the final conclusive result. And we thought of different ways to try to mitigate that. Fortunately, Susan at the time had, the Good to Go program was going on, so we could bring in people for an earlier HIV test. It didn't always work that way. But at the very beginning, when we started it, we thought we had to tell everyone about a positive 4th generation. And I still remember just like giving the news to people who then went on to be, false positives. Very, very stained in my brain as someone who, was a young woman with a partner, and they were driving wildly, like driving over to the AVRC, and they were like, we're so scared about this. And then she called it the day that she had AIDS, but then didn't. And there's a lot of education around it, but there was a lot of, when you didn't know for sure. And even if you can tell someone, we think this is probably a false positive, you don't know for sure. So fortunately, the testing that we were doing that took up to 2 weeks is now all been moved in-house. And usually we have all the results back within about 48 hours. 72 hours is sort of the, rarer outside. And then occasionally if there isn't a sample appropriate for viral load testing, that does have to be sent out or recollected. Very rare that occurs. So sometimes before we've even realized that the result is positive, the 4th generation, we now have a viral load and a confirmatory antibody test that are both negative. But it also creates a lot of confusion for teams that are seeing it. And this is something that we've been in discussions with the lab about, sort of how to change the reporting on it. But yeah, it's and yes, this false positive prevalence is true, and we definitely saw it when we changed the assay that we were using. I hope the thing that what we're seeing in Q1 of 2022 is just a little bit of a blip. But I think for, now that we've gotten used to this, we take the positive result that we might learn about with a grain of salt until we have more information. And fortunately, we get that information sooner. We've certainly identified, true positives that have been really important to do. Anyway, I don't know if Susan has anything else she wants to share just for the for the long history of doing this.
No, I mean, I think you've said it very well. I think we learned a lot, and I think it's hard to educate everyone who's doing the testing around the potential meaning of a false positive and the changing assays over time. And I think we've learned a lot. So yeah, I think this is very helpful.
And Michael,
yeah,
we're
that
really
historical
excited.
context of the change from the county doing the confirmatory testing to doing it here in-house. I remember being when I first started here at UCSD and being like, oh, we have to wait 2 weeks for confirmatory testing, and being very confused about things.
Well, I think that's one of the critical elements. I think it's really, for a test that's this important, I think it's critical that the testing all be done, in-house, because it's impossible to do it quickly if you split up the testing. And I think, the requirement that we had early on that confirmatory testing be done elsewhere was really problematic.
Agree. And then your point about, and I know Robert has his hand up, I'll get to him in a second. Oh no, I just lost what I was going to say. Maybe we'll turn to Robert. It's happening more and more. Robert, go ahead. Hopefully I'll come back. Oh, I got it. I'm sorry. The importance of case. I'm sorry. False news or fake news. No, the importance of case management, to be able to keep an eye on these results. And again, a lot easier now. We'll get emails from our case managers, Miriam and George, in the morning, and sometimes by the afternoon they're like, got the the viral load is resulted and it's negative. But just someone keeping an eye on it, so that when we have to disclose to patients and all of the wonderful focus providers that have done it, it just makes the job a lot easier. And then obviously when there are true positives, having the case management there to help link people is really essential. All right, sorry, Robert, go ahead.
Yeah, no problem. I like how I think you meant to say false start, but it came out as fake news.
Yeah, I could not come up with it.
We're too God, our news cycle. So can you remind me, just in Epic, when there is like a preliminary positive, or what's the first thing that people see? Do they see positive, or do they see that sent for confirmation, right? And
for confirmation. And it doesn't change.
Why do you think that is? Like,
I actually just emailed David Pride about this.
Yeah.
And it's interesting if you've ever seen the rapid test done, because it's done in the emergency room.
Yeah.
That one says prelim positive,
Right.
confirmatory testing pending. I think that's what it is, or maybe it's just confirmatory testing pending. The sent for is a relic, because yes, we used to send them somewhere, and I think they're going to update that so that it says. I just went through this whole thing. I think it's confirmatory testing pending or ongoing is what it says for that, and that would be the most accurate way to say it. We've talked about, can you ever change that result to positive?
Yeah.
And that's still a tricky and sticky situation. Once it's resulted, there's a link that you click on and it'll take you to the two confirmatory tests if they were both run. But it will never, yeah.
I mean, I can't, if this is, you'll know more than I will how big a problem this is, but I can't imagine this is like an Epic thing, because Epic is used everywhere, and I don't know if we're the only ones having this reporting problem.
I don't think it's
like what does Irvine do? What does Kaiser?
I don't think it's a reporting problem, and it has to do with the FDA approval and how you're allowed to report it.
Yeah. But then that would mean that like Irvine has the same issue, Kaiser has the same issue, do you know what I mean? Like every Epic, or everyone in the country. Yeah. If it's.
Yeah. I mean, again, ultimately, I think this is like a lot of tests that sometimes get reported in Epic where you're like, wait, I have to go searching for the result. I think Histo is a great example of that. So it's not that you have to go searching for it. Once you click on it, there's a link at the bottom that says like final result. the idea is that if someone did have a false positive, you wouldn't want it to say positive in their Epic record for the.
But I guess it could be changed, right? There's a comment about the VA
But
and how
it's not negative though, right? It's they did have a positive fourth generation test. So that would stay in there, and that could have lots of implications for those people, sort of similar to what Michael said. So it's tough, you know? Anyway, sorry, I see yeah.
Thanks.
I'm pretty sure the focus is on the people who are false positives, and what if you wrote positive antigen antibody test, even though the other things are negative, what would that, I think people would be very confused. It's tricky, yes. All right, and then Anik has a question: is the false positive rate higher when screening blood donors because not as much is done to check?
I don't know that the false positive rate is higher in screening blood donors. I guess let me go back to the slide where I think I had the blood donor stuff.
I guess my came from the fact that probably they're not doing all of these extra stuff to kind of be like, no, actually we got it wrong here, because they don't get the answer, right? It's like you donate and you never know whether, well, like, I don't know, like, oh no.
Well, this was also done, right? This was in 1991 to 95. So this is when, right? Mm-hmm. Is that the one we're talking about? And
yeah, this was done, this particular study was done with Western blot as a screening test, rather than
which we know also has
more modern screening.
Yeah.
So there was a lot of, I guess, cross-reactivity things, but also false positive prevalence is pretty low at that point. So like 0.0004% versus what we're seeing in our population is like 0.2% through the ED. So we have a higher one. I guess I do see your point of like they don't do all these additional steps just does someone have a positive antibody, and that may lead to higher potential screen out rates for blood donation. I don't know if I would, I guess, necessarily call those true false positives though.
I'm also asking because there was a colleague from another department asking about why men who have sex with men are still not allowed to donate because of, and he was saying, well, that seems insane given the very, very low false positive rate. And he wanted to prove that it didn't make any sense anymore not to allow MSM to be blood donors.
Yeah, I think that decision or that policy is probably more a political one than it is one strongly based in science. That's my general thinking. I don't know if other people have other thoughts about that blood donation policy for MSM.
Well, it's also changed, right? It's all very tricky and it's self-report, but you can donate now. MSM can donate now after 3 months of since their most recent sexual contact.
Okay, I didn't know.
So that. It's at least in the United States. I don't know what that looks like in other places. I apologize, but yeah, that was a pretty big change that was needed.
Yeah, I remember that happening.
Yeah. So. Yeah, so I guess a little bit of progress. There's another question here about why women, and you were saying gender, but really it's sex, because that's what we collect, unless you looked at gender identity, which is much harder to look at in EPIC because it's the data is pretty incomplete. So I'm assuming that it was the legal sex, which is the sex assigned at birth usually.
Yeah, these were sexes through EPIC, so whatever was reported in EPIC. So why did female sex have higher false positives? I don't think they have higher false positives. I think their increased prediction for having false positive testing, but I think that's just because the prevalence in our female sex population is lower. We did not have particular data on transgender women. I think both it's a data completeness issue through EPIC of like, people don't actually take the time to write out that this person's a transgender woman or take a history in that sort of way. So I think it isn't that they have higher false positive rates. They're just, if they are female sex, they're less predicted or less likely if they have a positive test to be a true positive.
The other thing that I'd add, and Michael, I'm so excited to see this paper since it looks like you've made a tremendous amount of progress. The one thing that I'd consider adding, although you just might not have enough, to make any meaningful data, what we're seeing in patients taking PrEP is an increase in false positive rates as well. And not that taking PrEP is associated with false positives, but if you're doing more testing in a certain population, you're going to see more of them. And it's certainly come up in the clinic space, fortunately not a lot. But there's a lot of verbiage around what to do with ambiguous HIV results in people taking PrEP. So I wonder if maybe towards, the later years, it's worth potentially looking at. I don't know how easy that will be. And likely it's a very small population coming through the emergency room.
Yeah, that's a good question. I think I always am skeptical about the appropriate history taking, and if someone's not actually in the UCSD system, actually writing down or reporting the appropriate medications that someone's on.
Totally.
So I think there's a lot of reporting bias in all this data that is very complex in terms of how to interpret and analyze it appropriately. But I do think it's something we can try to look at. I just don't know.
I think it was more just a note to people to think about also, even if we don't include it here. I think you're right.
I remember there was a patient recently that he had talked about that had been on PrEP, and there's
oh gosh, yes, that's still ongoing. Oh boy, right. And a patient is still very traumatized by that experience. So we know that it can be really, really difficult. So anyway, but I knew we'd be able to get through the time with this, Michael, and we can save your encephalitis case for another. I'll have you back in a few months. I don't know if anyone else has any other questions for Michael. Gabe, I don't know if Gabe is on. But Gabe led this work with Michael. So I don't know if he had anything he wanted to say. It doesn't look like he's on today. So, but I think this is great, and I'm excited to see the more completed project.
I got a draft out to Gabe, so
perfect.
Still working on some of the what we should do about some of the data. Again, like I said, I think a lot of it's really messy and trying to clean stuff and decide how to approach some of these things is interesting.
Yeah. All right. Well, thanks, Michael, so much. I again, this is very timely and relevant as a lot of us see things like this. Oh, there's one last comment. The DoD doesn't display a result until confirmatory tests are completed, except for rapid testing, but we feel this payment folks get tested elsewhere. And great talk. So, yeah, Michael, thank you so much. This was really great, very overview, great overview of the evolution of HIV screening testing and some of the pitfalls we still experience and how we think about those things. So thank you.
Thanks for having me on the talk, and I'll save this other talk about this patient later on.
Exactly. Tuck it in your back pocket. Well, and everyone else, thank you for joining us. We'll see you next week. I'm trying to think if there's any reason we're not joining. Nope, I think we are. So we'll see you next week. Bye, everybody.
Bye.